Thank you, Dr. Ayler. My name is Rod Quilitz, and I'm a clinical pharmacist for infectious disease as well as oncology here at HSV Moffitt Cancer Center. And today I will be doing a brief overview of the management of infections in immunocompromised patients. So there's a lot of material here, so what we'll ask is that we hold questions till the end so that I have some remote chance of getting through this material in the time allotted. Okay, no conflicts of interest to disclose at this time. Now, in terms of learning objectives, what I want to do is briefly review the risk factors for infections in oncology and solid organ transplant patients, and then discuss the predominant bacterial, fungal, and viral pathogens which cause infections in these patients, and then briefly review antimicrobial options we have to either prevent or treat infections in these patients. So I want you to have access to these key resources that I leaned on heavily for this talk. The first are the NCCN National Comprehensive Cancer Center Network Clinical Practice Guidelines for Prevention and Treatment of Cancer-Related Infections. That's available on their website. Also, Clinical Practice Guidelines for the use of antimicrobial agents in neutropenic patients with cancer, which is available at idsociety.org at the IDSA website. And also the American Society of Transplant ID guidelines, which are also available online for solid organ transplant patients, as well as the guidelines for preventing infectious complications in allogeneic stem cell transplant recipients. I think the bottom of that slide was cut off. Oops, technical difficulties. Please stand by. Okay, so moving on. So I'm going to start by talking about that which I know the most about, which is cancer, and talk about risk factors for infections associated with primary malignancy. So, for patients with hematological malignancies and myelodysplastic syndrome, aplastic anemia, these patients may be at increased risk for infection due to neutropenia that's either due to bone marrow involvement of their underlying malignant disease, or patients who have received multiple cycles of chemotherapy and therefore have reduced bone marrow reserve. Another infectious risk in these patients is hypogammaglobulinemia, which results in increased susceptibility to encapsulated bacteria, such as Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. And we see this predominantly with chronic lymphocytic leukemia and multiple myeloma. And of note with IgG-based multiple myeloma, since it's a plasma cell malignancy, you may have a very high IgG level that is that's predominantly monoclonal, but you may still have functional hypogammaglobulinemia. Okay, another risk factor is anytime you disrupt the mucosal membranes due to radiation therapy or chemotherapy, you have a breakdown of the barrier to infection. This can be in the GI tract, sinopulmonary or GU tracts, and the concern is invasion of local flora. And this is particularly significant in combination with neutropenia. So, for example, in neutropenic patients who have these disruptions to their mucosal membranes, they're at increased risk of bloodstream infections, such as virulent strep, particularly Streptococcus mitis, which is a big problem in patients with stomatitis. Also, Candida or aerobic gram-negative rod translocation from the GI tract. And when you have a combination of enteritis plus neutropenia, this is called typhlitis or neutropenic enterocolitis, and here you worry about polymicrobial translocation from the GI tract, including anaerobes. Okay, some of these patients may be functionally asplenic, increasing the risk of the same encapsulated bacterial infections I mentioned before. This can be due to having received splenic irradiation, or patients with chronic graft-versus-host disease may be functionally asplenic. And traditionally, we've considered penicillin prophylaxis in these patients, but we have to be aware that this is becoming less effective as we see more and more penicillin-resistant strep pneumoniae. So these patients should be evaluated for possible pneumococcal or meningococcal vaccination. Okay, now neutropenia has kind of been the bread and butter of these kinds of talks because it's the single most important risk factor for the development of an infection during chemotherapy for cancer. So we have to consider a couple things. One is the severity of the neutropenia. So the highest risk for infection is when the ANC drops below 100. Also, patients with a very rapid decline in their ANC as they head into their nadir. Both of those are associated with reduced bone marrow reserve. And duration is critical. The greatest risk for infections also occur in those patients where their ANC is less than 500 for more than 10 days. And that's where we start greatly expanding our prophylaxis, for example. So it can be an issue because cancer patients often have blunted inflammatory responses, so we may miss some of the usual signs and symptoms of infections. So fever becomes critical, and what we're defining as fever by the latest IDSA guidelines is a single oral temperature of greater than 38.3 degrees Celsius or oral temperature of 38 degrees Celsius that persists for over an hour. Now, in most of the documented infections in febrile neutropenia, especially early febrile neutropenia, are bacterial pathogens. And as you can see in this graph, you get a mix of gram-positive and gram-negative bacteria. Now, if we could extend this data forward, we are seeing a mix. It'd be interesting to see whether it's more gram-positive, more gram-negative. We're seeing more gram-negative because of more resistant E. coli, Klebsiella pneumoniae, and so forth to ciprofloxacin and quinolones. But we're also seeing more gram-positives, and that we're seeing more vancomycin-resistant enterococcus. Other pathogens in the setting of neutropenic fever include fungus, which make up about 10 to 20%. This is usually secondary to the fact that we've given broad-spectrum antibiotics to a patient with neutropenia, and we kill down the bacterial flora, and we wind up with overgrowth of Candida. Aspergillus is a risk factor, as we'll discuss later, for those patients with prolonged neutropenia. And kind of last of all here is viral. Viral infections only make about 5 to 10% of all documented infections in neutropenic patients, and the vast majority of this is going to be herpes simplex virus, much more so than varicella zoster or cytomegalovirus, which are later infections. So depending on the patient population, how long neutropenia is, and what kind of prophylaxis used, a substantial number of these patients actually have an established or occult infection. We have to assume that the patient coming in with their first neutropenic fever has a bacteremia. And there's a substantial early mortality associated with bacteremia in these patients if they are improperly treated. Now, we can reduce the risk of these infections by using antimicrobial prophylaxis, but this comes as a trade-off being that we feed into antibacterial resistance, and we're seeing this with the quinolones certainly now. Also, we're increasing the risk of secondary infections such as Clostridium difficile colitis. Okay, now moving away from the neutrophils to the lymphocytes for a second, certainly we give therapy that can have a negative effect on lymphocytes. And corticosteroids are the first one you think of, right? So the risk of opportunistic infections in these patients increases with the dose and duration of the corticosteroids, as well as patients' coexisting immunodeficiencies, as well as additional immunosuppressive medications that these patients may be on. So corticosteroids are really the masters at blunting fever and signs of infections. That's something we have to keep in mind when assessing these patients, especially if they're also neutropenic. Also, some of our cancer chemotherapeutic agents, such as fludarabine, the purine analogs, are lymphotoxic, especially to the CD4 positive lymphocytes, the helper lymphocytes. And if you take fludarabine and you combine it with prednisone, you can have a CD4 depression, which can last for months after therapy, making these patients similar to a AIDS patient in terms of their infectious risk. Now, the king of all these anti-lymphocyte drugs is called alemtuzumab or Campath, and this is a monoclonal antibody against CD52, which is a protein found on the surface of most normal lymphocytes. We use this drug for CLL. It results in a severe lymphopenia of CD4 and CD8 counts. In some patients, these counts are suppressed for more than 12 months after therapy. So these patients need to be on PCP prophylaxis. They need to be on HSV prophylaxis for at least 2 months after therapy, and ideally you repeat their CD4 count and see where you are. Also, these patients need to receive regular testing for CMV viremia, which can lead to CMV pneumonia. So they may need preemptive therapy. Okay. Stem cell transplant, what we used to call bone marrow transplant. So it's going to be divided into autologous and allogeneic stem cell transplant for the most part. And the autologous transplant patients are receiving their own cells back. So their risk is associated with conditioning chemotherapy, the neutropenia and mucositis. So most of their infections occur during this initial period of neutropenia, but they're still at risk for infection for greater than average risk for infections for about 3 months after stem cell transplant until recovery of cellular immunity. The allogeneic stem cell transplant patients, on the other hand, they are at considerably higher risk of infection. And you break it down by the timeline based on day of transplant, right? So pre-engraftment up to day plus 30, this is where we're predominantly worried about neutropenia and mucositis, toxicity of their chemotherapy, but we also have some early acute graft-versus-host disease here. All these patients have central lines. When you get to phase 2, that's about day 30 to 100. Now we are talking about more deficiencies in cellular and humoral immunity. We have patients who are receiving treatment or prophylaxis for acute and or chronic graft-versus-host disease, and they still have central lines. And in phase 3, you have the late period where you have deficiency in cellular and humoral immunity, chronic GVHD concerns. So as far as what kind of bugs these patients get, this timeline is helpful, right? The respiratory and enteric viruses can pop up at any time, but HSV, for example, tends to be an early complication, while CMV and VZV tend to be later complications, as mentioned before. Your gram-negative, most of your bacterial infections are going to be during the period of the neutropenia and mucositis, although certainly the line-related infections can be there anytime you have a central catheter. We can also see yeast during the period of neutropenia and mucositis, but also patients who are on long-term corticosteroids are at increased risk. And if we look at the molds, we kind of have a biphasic risk factor there. We have the patients who have prolonged neutropenia initially, and then we have those patients who recover from their neutropenia, develop graft-versus-host disease, go on high-dose corticosteroids or other lymphotoxic drugs, who are at increased risk. Also, we have pneumocystis jirovecii and toxoplasma, which are other late complications of transplant. In terms of solid organ transplant, I will confess that I don't have as much personal experience as I do in the oncology setting, but for solid organ transplant patients who are immunocompromised, you have different periods of infectious risk, right? So early on, you're talking about your nosocomial or technical related infections, and then that's usually in the first 4 weeks. That's where you tend to see more of your classic nosocomial organisms, and they're listed here on the slide: MRSA, VRE, Candida species, etc. Reactivation of HSV. If the recipient already had Aspergillus or Pseudomonas colonization before, these can grow to become infectious complications. Whereas in the 1 to 6 month period, you tend to have more of the activation of latent infections, relapse, residual, and opportunistic infections. So your PCP and CMV prophylaxis or empiric therapy is very important in preventing many of these complications, but you can still be at risk for things like the polyoma viruses, C. diff, hepatitis, adenovirus, influenza, cryptococcus, TB, etc. And after about 6 months, you're usually considered more of a community-acquired infectious risk factor, although if patients have rejection episodes, they might get pushed back into that higher risk category. Okay, so now I'm going to move from talking about risk factors to talking about some of the specific kind of infections that we have to deal with. And so this slide has a list of some of the more common bacterial pathogens in neutropenic patients, since that's where we see the majority of our bacterial infections in cancer patients. So you have your gram-positives, your coag-negative staph line infections, Staphylococcus aureus, including MRSA, which is certainly something we want to screen these patients for. Intercoccal species, including VRE, which we also screen our high-risk patients for. Viridans group strep, like that strep mitis from the oral flora I mentioned before. Strep pneumoniae, which is usually associated with an underlying severe infection, pneumonia being most common. Group A strep associated with cellulitis. And then our aerobic gram-negative rods. And then, of course, we have to be aware of some of the more resistant organisms, such as Pseudomonas, Citrobacter, Acinetobacter, and Stenotrophomonas in these patients. Okay, when evaluating a patient for neutropenic fever, you actually divide these patients up into low risk versus high risk. And low risk patients are those with a shorter duration of neutropenia, minimum comorbid conditions, which is kind of summed up in the MASC score of less than or equal to 21, which is Multinational Association for Supportive Care in Cancer Risk Index score. So patients who are at low risk are potential candidates for oral or outpatient therapy, whereas high-risk patients have longer neutropenia, more severe neutropenia, and or significant medical comorbid conditions, and they need to be admitted for IV RX. So patients who are truly low risk and can get adequate follow-up are usually treated with amoxicillin augmentin plus ciprofloxacin. Obviously, they couldn't have had quinolone prophylaxis. High-risk patients, however, are admitted. They receive therapy with an anti-pseudomonal beta-lactam as monotherapy classically, so cefepime, piperacillin, tazobactam. Carbapenems, other than ertapenem, work, but we try to save those for patients with a history of multi-drug resistant infections. Vancomycin, we used to add in practically everyone with a neutropenic fever. Now, consistent with the latest IDSA and NCCN guidelines, we ratcheted that down to those patients who are hemodynamically unstable or have pneumonia documented radiographically, so we have extra MRSA and strep pneumo coverage. Positive blood cultures for gram-positive bacteria before we have the final identification susceptibility. Clinically suspected serious catheter-related infections or any kind of skin and soft tissue infection at the time of the neutropenic fever. And if they're colonized with MRSA, we're going to give them vancomycin if they're colonized with penicillin-resistant strep pneumoniae. And if they're colonized with VRE, we're going to give them either daptomycin or linazolid as an initial empiric therapy. And severe mucositis is not automatically an indication for vancomycin anymore, unless you're using a drug like ceftazidime or estrianem that has poor or no strep coverage, whereas cefepime, zosyn, and the carbapenems have excellent empiric strep mitis coverage. And then we need to reassess the need for continuing the gram-positive agents after 48 to 72 hours. Do they actually have any of these infections that we're concerned about? The addition of extra gram-negative drugs, aminoglycosides or fluoroquinolones, if patients did not receive fluoroquinolone prophylaxis, right? Again, if you have a septic patient, if patients have a positive culture for gram-negative bacteria, especially bacteremia, and consider in patients with a recent history of multi-drug resistant gram-negative rod infections, such as Pseudomonas, and reevaluate the needs to keep the aminoglycoside or fluoroquinolone going after 48 to 72 hours based on culture and sensitivity data. Anaerobic coverage is not routinely added to these patients, except for the situations of neutropenic enterocolitis or typhlitis. If the patient has severe right lower quadrant abdominal pain, then we're going to want to add metronidazole. If we had selected an anti-pseudomonal beta-lactam, cefepime, which lacks anaerobic activity, but if you chose zosyn or carbapenem, then there's no need to double cover with metronidazole. Also, we will add metronidazole for suspected or documented Clostridium difficile colitis. So, when do we prophylax these patients? The NCCN guidelines and the IDSA guidelines are more or less in agreement that we consider fluoroquinolone prophylaxis, cipro or levofloxacin, in patients receiving myelosuppressive chemotherapy if they're going to have greater than 10 days of neutropenia. Most authors will recommend that. Consider it for those intermediate risk of 7 to 10 days of neutropenia. Now, levofloxacin may be preferred for patients at risk of invasive virulent streptococcal infections when they're expected to have severe mucositis, although I have to tell you there's a fair amount of levofloxacin-resistant strep mitis out there. But they're all resistant to cipro, so I understand where that's coming from. Clostridium difficile is a problem throughout the healthcare system in both immunocompromised and immunocompetent patients, of course. This organism being the primary responsible organism for antibiotic and or proton pump inhibitor associated diarrhea and colitis, and causing severe mucosal inflammation and severe diarrhea, and can of course be life-threatening. We do use more or less the standard guidelines for selection between metronidazole and vancomycin, meaning that most of our patients wind up receiving metronidazole because we don't have a profound leukocytosis. But if you do have a a bump in the serum creatinine compared to the premorbid level, or you have a patient who has severe complicated C. diff, then we will follow the IDSA SHEA guidelines there. Very much in passing, I'm going to mention Fidaxomicin, which has been FDA approved, DIFICID, which is bactericidal against C. diff in vitro, so it gives us another option. It's been FDA approved based on 2 clinical trials. What we've seen is at end of therapy, there's no difference in response between the 2 agents. There is a difference of about 12 to 15% better sustained response at delayed follow-up. And the big question now is, can we find out which patients are most likely to benefit, because there's a major cost-effectiveness question with this agent. Okay, leaving the bacteria behind, I'm going to move forward and talk about fungi. This slide kind of encapsulates some of those fungus that tends to be the most problematic clinically. I'm not going to have time to go into each and every one of these, but we're going to hit some of the more common yeasts, molds, and touch base on the dimorphic fungi. So relative risk factors for invasive fungal infections basically comes down to duration of neutropenia, as well as severity of lymphopenia as reflected by your CD4 count. So starting with Candida, yeast infections. Yeast is now the 4th most common ICU bloodstream infection. Right, usually after coag-negative staph, Staph aureus, and Enterococcus, depending on what series you're looking at, may even be for some of the gram-negative rods that we tend to worry about. So think about candidemia in a septic patient, particularly if they're neutropenic, if they have hematological disease, if they're diabetic, they're otherwise immunodeficient, are on high-dose steroids or other immunosuppressants, they have a central venous catheter, dialysis, TPN, they've been on multiple antibiotics, or they had a recent extensive GI surgery, and we may have disseminated candidiasis in the absence of positive cultures. So that's something for us to be aware of. The purpose of this slide is just to show you some of the sites that disseminated candidiasis can go to. So on the far left, we have the Swiss cheese liver, consistent with hepatic splenic candidiasis. On the upper right, if you see those the very round nodules, those represent like a septic emboli kind of picture. That's in the lungs. That's kind of the one scenario where you might see a Candida pneumonia. And of course, we have to worry about ocular involvement as well with Candida. Why do we worry about this, about yeast in so much? Well, when you look at stem cell transplant patients and solid organ transplant patients, we're looking at about a 24% attributable mortality in these patients. So we take that very seriously. When we think about Candida, it's important to understand the antifungal spectrum, right? So Candida albicans is going to be susceptible to basically everything we have to choose from. But you tend to hear people saying, well, it's non-C. albicans, so it's got to be fluconazole resistant. And that's not necessarily true, right? You have Candida parapsilosis is usually highly susceptible to fluconazole, Candida garramundi, for example, Candida tropicalis. The fluconazole resistant or potentially resistant organisms include Candida glabrata, which likes to create efflux pumps and pump out azoles. So you can have fluconazole susceptibility or resistance, or you can have a middle ground called dose dependent, where you may have to ramp up your fluconazole dose to at least 800 milligrams a day to treat these patients. You really need susceptibility data in order to make that determination. But just be aware, if you have resistance, if you have these efflux pumps active, then Vori and Posa may lose their activity as well. You may be better off with an echinocandin or a polyene. Candida krusei is intrinsically resistant to fluconazole, but voriconazole and posaconazole will usually maintain activity against Candida krusei. Echinocandins are considered the treatment of choice, as well as amphotericin. And if you're going to have a breakthrough on the echinocandins, it's usually going to be with Candida parapsilosis or Candida garramundi, which tend to have a little higher MICs to our echinocandins. Okay, Cryptococcus. Cryptococcus is a ubiquitous occurring encapsulated yeast, and it's common in the soil and pigeon droppings. It's acquired by inhalation, and the most common sites of infection include the lungs, right? Patients can have cough, rales, shortness of breath, but we also patients can also have CNS infections. They can have these non-specific meningeal symptoms. So we think about Cryptococcus neoformans as being the problematic species here. This is a non-contagious systemic infection in profoundly immunocompromised patients, such as end-stage AIDS patients, but we can also see it in solid organ transplant or in allogeneic stem cell transplant patients. But now we have to be aware that there's a new kid on the block, and that's Cryptococcus gattii, and it started as an outbreak among immunocompetent patients in the Pacific Northwest, and it's been making its way across the country since. And we've actually seen one case of Cryptococcus gattii meningitis. So, Cryptococcus is going to be treated for isolated pulmonary disease. For mild to moderate disease, you may be able to treat with fluconazole, but for patients with severe disease, you're going to want to use a amphotericin B formulation, either conventional or lipid, until the patient has clinical response, and then switch to fluconazole. Whereas for cryptococcal meningitis, you're going to use a combination of an amphotericin formulation plus flucytosine for at least 2 weeks, which you can follow with fluconazole for completion of 10 weeks of therapy, or 6 to 10 weeks of an amphotericin plus 5-FC. And you have to consider your patient's relative immunocompromised state. Likely the patient will require suppressive or maintenance azole therapy, probably fluconazole, after treatment. Okay, moving away from the yeast, moving to the molds. Our big enemy here, most common enemy is Aspergillus, and this is a ubiquitous mold found in soil, water, and plants. And the most common species include Fumigatus, Flavus, Niger, and Terreus. Aspergillus can cause superficial infections, such as infected skin scrape. You can see allergic pulmonary reactions. It can be an allergen. But the big thing we worry about are these aspergillomas, fungus balls in the lungs or CNS. And we also worry about invasive disseminated infection with Aspergillus. So it's kind of a busy slide, but I want to mention on the right-hand side, you see that dramatic relationship between duration of neutropenia and the incidence of invasive pulmonary aspergillosis. Right? This is old data, so this is more like the natural history without aggressive prophylaxis. But as you can see, once you get past 10 days, the risk really skyrockets. Also, this organism is difficult to diagnose because often your cultures are going to be negative. You may have a positive respiratory culture, sputum or BAL, which that may represent infection, or it may represent mere respiratory colonization. And even if you biopsy, you get a bronch, you usually only get a identification of this in about 40% of cases. CT scans, not necessarily high resolution, and we don't need contrast for this, are the main way that we identify suspected Aspergillus infections in these patients. Galactomana assays can also be used to try to give us an early warning sign in these patients, but the limits of this lab test is because you have false positive in patients who are receiving Zosyn, and has reduced sensitivity in patients on anti-mold agents. Plus, you get enough false positives that you always have to repeat it and get 2 positives before you trust it. On this slide, we have a couple pictures of Aspergillus as seen via CT scan. And the top picture gives you the classic halo sign, your ground glass attenuation surrounding the nodule due to alveolar hemorrhage. Right? This is due to bleeding. Aspergillus is angioinvasive. This is an early sign of Aspergillus, and you see progressively less of the halo sign over time. On the lower of the 2 pictures, you're going to see the air crescent sign, which indicates an area of necrosis. This is a later sign, and it's not seen during neutropenia because you don't have enough neutrophils to attack. It's analogous to what we saw with hepatic splenocandidiasis. So we worry about aspergillosis because even though we have seen some improvements in the mortality rates due to the availability of newer and less toxic agents being used more aggressively, we still have substantial mortality associated with Aspergillus infections in this patient population, as you can see here and here. Okay, now in terms of what drugs do we have, of course we lose fluconazole anytime that we're talking about molds. Voriconazole and posaconazole actually have the best in vitro activity against Aspergillus, and we like voriconazole because the absorption is more reliable than posaconazole currently. The echinocandins are static against Aspergillus, and amphotericin B remains an excellent choice, except for Aspergillus terreus, which is intrinsically resistant to amphotericin. So before voriconazole, all we had was amphotericin. Most of these patients wound up dying, often without knowing that we had terreus. Okay, this is the key randomized study that showed compared voriconazole versus amphotericin B for initial treatment of invasive aspergillosis. And these patients were randomized to receive either amphotericin B conventional 1 to 1.5 mg per kg per day or IV voriconazole. Interestingly enough, they wound up on voriconazole for about 77 days, but only about 10 days for amphotericin B, because almost everyone developed nephrotoxicity. About 80% of these patients had to be switched. Bearing that in mind, there was superior success at 12 weeks, and more importantly, survival at 12 weeks, 71% versus 58% for the ampho group. And this was statistically significant, and voriconazole is therefore considered to be the first-line treatment of choice for invasive aspergillosis. Moving from aspergillus to fusarium, this banana-shaped mold here, found in soil, plants, and water, and we can see superficial infections, keratitis, onychomycosis. We can see locally invasive infections, and we can see disseminated infections in severely immunocompromised patients. Most common species being Solani, about half of them, Oxysporum, 20%, Verticuloides, 10%, Maniliforme, 10%. And this is the number one cause when we see one of our prolonged neutropenic patients with a swollen toe. This is what we worry about, especially if it's near the nail or interdigital. So we wind up biopsying them or removing the nail. And if we have a dermal disseminated lesion, then we need a deep biopsy of that. Also, fusarium, unlike the other molds, your blood culture may be positive if your patient has disseminated fusarium. Here's an example of a patient with a swollen toe, and now he's starting to have some erythema that's progressing from that initial site. And this patient needs to be very aggressively treated in the setting of prolonged neutropenia, or we may have to consider amputation of this foot if this progresses. This is a gentleman with multiple cutaneous lesions from disseminated fusarium. Okay, so in terms of what fusarium, is going to be voriconazole and amphotericin B are going to be your most potent agents. So we usually use voriconazole in combination with ambisome in these high-risk patients. Some of the other molds that I wanted to touch on very briefly: Pseudospermum epispermum. You have voriconazole and posaconazole would be your treatments of choice, usually Vori. S. prolificans is actually a really bad bug in that we don't really have any great antifungal therapy for it. Throw the kitchen sink at it, basically. And then the zygomycoses I'm going to talk about in a moment. We lose voriconazole now. We have posaconazole and amphotericin. And the demediaceous molds such as Alternarium bipolaris, again, the extended spectrum azoles for these rare but potentially serious infections in immunocompromised patients. Zygomycoses. Okay, so these are the molds from the order Mucorales, such as Absidia, Cunninghamella, Mucor, and Rhizopus. And these can cause gastrointestinal, rhinocerebral, maxillofacial, pulmonary infections, particularly in our prolonged neutropenic patients with hemalignancies, and also seen with very poorly controlled diabetes. Now, the mortality rate's about 44% in the diabetics, about 66% in the malignancy patients. And this slide shows an example of this large wedge-shaped nasty nodule that this is actually a Cunninghamella pneumonia that we successfully treated with ambisome plus posaconazole. So you see the initial scan, and you see a month later on therapy. Fortunately, this patient did recover his neutrophils, so we were able to successfully treat this infection. Okay, I mentioned the susceptibility profile of the zygomycoses. Of note, there are a series of murine studies that suggest a benefit of combination therapy with amphotericin B and an echinocandin, which is surprising because echinocandins in and of themselves don't have any activity against zygomycoses. Also, I want to mention that the chelation therapy, and I think some of my slides were cut off on the bottom, unfortunately. But be aware that deferoxamine actually increases the risk of zygomycotic infection because it liberates free iron during the process of chelation, whereas desferol or XJADE or Deferizox has actually been shown to have in vitro activity against zygomycoses because it more tightly binds free iron, potentially starving zygomycoses. Preliminary clinical studies, up to 20 patients, have not really shown the benefit we were hoping for, though. Okay, finishing up the yeasts here, the fungi, excuse me, with the dimorphic fungi. I actually don't see very much of this in Florida because we're not in any of these zones, but we, of course, get patients traveling back and forth, so we have to be aware. Histo is endemic in Ohio and the Mississippi River Valley region. More than 90% of our patients are exposed, the vast majority asymptomatic. These patients can have acute or chronic pulmonary disease, disseminated disease, particularly in immunocompromised patients. Blasto is endemic to south central U.S. and the Great Lakes area. You have acute pulmonary disease with fever, shortness of breath, purulent cough with or without hemoptysis. You can have sporadic symptoms of low-grade fever, night sweats, or cough, and you can have extrapulmonary disseminated disease, including CNS disease in immunocompromised patients. Cocci can give like a community-acquired pneumonia kind of picture, but also there can be chronic sequelae with fatigue, arthralgias, cutaneous lesions. This is endemic to southwest U.S. and parts of Mexico and South America, and you can kind of continuously reinfect yourself because the arthroconidia spores are inhaled into the lungs, transfer into spherules, which rupture to form endospheres, each which may produce another spherule, causing reinfection. And we see primary, including CNS disease, in less than 1% of infected patients, but certainly immunocompromised patients are at higher risk. So, in terms of the dimorphic fungi, again, I apologize, some of these slides didn't translate perfectly over. But it's itraconazole and amphotericin are considered your mainstay of therapy, right? Amphotericin for your severe disease and eventually transitioning over to complete your therapy with itraconazole. Okay. So what do we do to prevent fungal infections in these patients? Well, I think the NCCN guidelines really goes into it in the most helpful detail here. They break patients into acute lymphocytic leukemia, where fluconazole is the mainstay of antifungal prophylaxis, because these patients don't tend to have as long a neutropenia, less mold risk, right, as compared to our MDS or AML patients who need an anti-mold active agent such as posaconazole or voriconazole. Our autologous stem cell transplant patients with mucositis should get fluconazole or mycofungin. Without mucositis, they may not need prophylaxis. Most centers still give fluconazole. Our allogeneic stem cell transplant patients to their period of neutropenia, fluconazole is an acceptable option. Other options that have been studied and not have been shown to be clinically superior include mycofungin and the anti-mold active agents. However, patients with allogeneic stem cell transplant and significant graft-versus-host disease who end up on high-dose corticosteroids, these patients should have some kind of anti-mold prophylaxis. One last mold, because this is a mold, Pneumocystis jirovecii pneumonia, right? This is a diffuse fungal infection which produces this diffuse ground glass pneumonia in lymphopenic patients, and this is a major cause of morbidity and mortality in immunocompromised patients without prophylaxis. And so there's all kinds of dosing for Bactrim prophylaxis in these patients, including 1 tab daily of single strength or double strength 1 tablet 3 times a week. And the treatment of choice is going to be Bactrim at 15 to 20 milligrams per kilogram of trimethoprim per day in 3 to 4 divided doses for 21 days, and consider the addition of prednisone based on the patient's oxygenation status. PCV prophylaxis, it's recommended to prophylax allogeneic stem cell transplant patients for at least 6 months following immunosuppressive therapy. We do it for a year. For patients with ALL throughout their anti-leukemic therapy, patients with CAMPATH I've already mentioned, that is necessary. Consider for patients who receive T-cell depleting agents such as fludarabine and other purine antagonists, patients who receive prolonged corticosteroids, right, 20 milligrams per day or higher for at least a month, patients receiving temozolomide plus XRT for glioblastic multiforme brain cancer, and then possibly autologous stem cell transplant patients for 3 to 6 months after transplant. Okay, so I've talked about bacteria, I've talked about fungus. I'm going to talk about, very briefly, some of the more common viral infections that you can see in these patients. Certainly not a complete laundry list here. So HSV1, HSV2, herpes simplex virus is an alpha herpes virus which establishes latency in the nerve root ganglia. HSV1 gives you predominantly oral labial infections. HSV2, of course, gives you predominantly genital infections, but you can see vice versa. We see more severe and frequent mucocutaneous HSV infections in patients with neutropenia, in solid organ transplant patients, in stem cell transplant patients as well. So, and it's important to note that oral or esophageal HSV can aggravate chemotherapy-induced mucositis. I have seen patients who actually needed to be electively intubated to preserve their airway because of the combination of chemo and HSV mucositis. Rare, thank God. Visceral or disseminated disease can occur from HSV, and you can see disseminated cutaneous disease, patients with esophagitis, hepatitis, pneumonitis, or encephalitis. So here are a couple of pleasant slides showing HSV-induced stomatitis, particularly in these patients. This is a relatively rare but cool slide, so I put it in there with eczema herpeticum caused by HSV1. And this is a slide showing temporal lobe white matter changes associated with HSV encephalitis. So, prevention and treatment of HSV. Let's talk about the solid organ transplant patients for a moment, give them their chance. Now, in solid organ transplant patients, if they're getting cytomegalovirus prophylaxis, then that's going to cover HSV as well. If they are not, however, for example, they're getting preemptive therapy that we'll talk about, they should be getting either oral acyclovir or valacyclovir or famciclovir prophylaxis for at least 1 month during treatment of rejection episodes, and treat. Obviously, we're going to treat more aggressive. We're going to use more aggressive doses of these same agents for treatment of mucocutaneous disease. If we have severe visceral disseminated disease, we're going to prefer IV acyclovir. Certainly, we're going to avoid oral acyclovir with only 10 to 20% absorption. And we have to use foscarnet for acyclovir-resistant HSV. For VZV, of course, we have primary varicella or chickenpox, right? Gives us fever and rash, vesicular, pruritic, usually for 7 to 10 days in immunocompromised patients like most of us who were, pre-immunization. But you can have rare, life-threatening visceral infections leading to hepatitis, pancreatitis, pneumonitis, and encephalitis. Again, particularly in immunocompromised patients, but not only in. And this is followed by lifelong latency where the VZV becomes dormant in the cranial nerve and dorsal root ganglia. Then you get herpes zoster or shingles occurring years to decades later, and you get these vesicular lesions usually limited to a single dermatome. You have, of course, post-herpetic neuralgia and increased incidence and risk of dissemination with immunosuppressive therapy, especially patients with heart transplant, lung transplant, or allogeneic stem cell transplant patients who are getting the most heavy immunosuppression. And here is a case of disseminated VZV. So obviously this can be dramatic for our patients. And we're going to treat VZV, outpatient treatment. Theoretically, you give acyclovir 800 milligrams 5 times a day. That's always my last resort due to the terrible absorption of oral acyclovir. So I'm going to use either valacyclovir or famciclovir with TID dosing for patients with acute, patients with severe infections such as the one we just saw. They're definitely going to get high-dose IV acyclovir, 10 milligrams per kilogram IV Q8 hours, as compared to the 5 mg per kg that we use for most HSV infections other than encephalitis. So who do we prophylax? versus VZV or HSV. So for patients with short duration of neutropenia, less than 7 days, they usually don't get prophylaxed unless they have a history of recurrent HSV. For patients at intermediate risk, consider HSV prophylaxis and strongly recommended in those who are going to be neutropenic longer than 10 days, like your acute leukemics. I will mention a couple. Mentioned Campath before, an allogeneic stem cell transplant. We continue for a year out from the transplant or longer if they're still on immunosuppressive therapy. Interestingly, bortezomib or Velcade has been associated with VZV reactivation, so we actually recommend at least a year of acyclovir prophylaxis for these patients as well. Okay, CMV or cytomegalovirus, one of our main enemies in allogeneic stem cell transplant. Want to divide this up between what a CMV infection is, which means you have viral replication. It's not latent, and we can monitor this via CMV DNA by PCR or by pp65 antigenemia. But then once you have actual CMV infection in combination with symptoms, now you have CMV disease, and this can be about the general viral symptom with fever, malaise, leukopenia, thrombocytopenia, or this can be a pneumonitis, hepatitis, retinitis, GI disease, or encephalitis. And this is a major cause of morbidity and or mortality in solid organ transplant and allogeneic stem cell transplant patients. For solid organ transplant patients, the biggest risk is for patients where the donor is positive for CMV and the recipient is negative. And the more immunocompromised, the bigger the concern here. So we see bigger problems in lungs, small intestine, and pancreas transplants than liver or kidney. For allogeneic stem cell transplant patients, it's usually reactivation of the recipient rather than receiving it from the donor, although that can happen. And patients who are CMV negative and donor negative and recipient negative have minimal to no risk of CMV disease unless they receive it through a blood transfusion. So we always use CMV negative or leukocyte depleted blood products. So this slide shows you, the severe life-threatening case of CMV pneumonitis. These patients, this severe disease, obviously tend not to do well. So our first-line treatments for CMV in these patients, ganciclovir, the usual dose is 5 milligrams per kilogram IVQ12. Dose-limiting toxicity is myelosuppression, especially anemia. We need to dose this drug, just this drug's dose for renal insufficiency. CMV resistance against ganciclovir is rare in previously untreated patients, but it can be seen in patients who've received multiple courses of treatment for CMV. And we have the alternative of giving oral valganciclovir, which is a prodrug for ganciclovir, at 900 milligrams twice a day with food. It has about 60% bioavailability, so this has been useful for us. Or our second-line therapy is generally foscarnet, 60 milligrams per kilogram IVQ8 or 90 milligrams per kilogram Q12. But the concerns here are side effects include nephrotoxicity, electrolyte wasting, potassium, magnesium, calcium, phosphorus, genital ulcerations can occur. These patients should receive concurrent saline for sodium loading to reduce the nephrotoxicity with foscarnet, if at all possible. And foscarnet's nephrotoxic and renally eliminated, so you have to adjust its dose for renal insufficiency. To prevent CMV disease, we have a couple choices. We can either prophylax these patients, giving them ganciclovir or valganciclovir during the period of risk. And that's actually where we have the largest randomized trials in both allo transplant and solid organ transplant. So the advantages to do it for prophylaxis is we've got really good data to show that this works. It's relatively easy to coordinate as compared to preemptive therapy, where we check the CMV by PCR blood or the antigens and treat based on a threshold. But we do have a problem with late onset disease after you stop the prophylaxis. It tends to be less of a problem with preemptive therapy. Your drug costs are higher for prophylaxis. Your lab costs are higher for preemptive therapy. Toxicity is what tends to lean us one way or the other here, because you get significant drug toxicity with these anti-CMV agents. And if you give preemptive therapy, you have shorter courses of antivirals and less drug toxicity to patients who may not have developed CMV disease to begin with. Now, in terms of some of the indirect effects of CMV, graft loss, mortality, opportunistic infections, prophylaxis may be more effective than preemptive therapy. So we have valganciclovir, oral ganciclovir, IV ganciclovir, and very high-dose valacyclovir have been used for prophylaxis. Just be aware that oral ganciclovir has extremely poor bioavailability and a high pill burden, still used for prophylaxis in some solid organ transplant protocols, but we don't use it in stem cell transplant patients at all. And very high-dose valacyclovir has shown some prophylactic activity against CMV, although we'd never used to treat it, of course. Okay, and NCCN recommends that allogeneic stem cell transplant patients receive surveillance for up to 6 months after transplant or longer if they develop graft-versus-host disease and are on prolonged immunosuppressive agents. And we had mentioned, of course, that we have to do the same thing for patients with receiving alemtuzumab. Okay, I wanted to mention human herpes virus 6. HHV6 is a lymphotropic beta herpes virus. It's the cause of rosacea, roseola, excuse me. HHV6A and 6B are the two subtypes. 6B causes the majority of acute infections in children and reactivation in immunocompromised patients. Again, lifelong latency in mononuclear cells. HHV6 viremia occurs in 40 to 60% of allo stem cell transplant patients. It's usually asymptomatic, although you can have a fever, bone marrow suppression, much more common than visceral disease such as pneumonitis, hepatitis, or colitis. There's about a 1 to 2% incidence in allo stem cell transplant patients of HHV6-associated limbic encephalitis, which is a very poor prognosis. HHV6B disease can be treated with ganciclovir or foscarnet, and usually we use ganciclovir unless they're neutropenic at the time. HHV6A is more likely to be ganciclovir resistant, so we'll preferentially use foscarnet. Adenovirus is a non-enveloped double-strain DNA virus, usually associated with self-limiting respiratory, GI, or conjunctival disease in immunocompetent patients, especially kids. In solid organ transplant patients, the effects vary by the organs involved. So you can see hepatitis or graft failure and liver disease, pneumonia, graft failure and lung disease, hemorrhagic cystitis or nephritis in kidney transplant patients, enterocolitis in patients with small bowel transplant. And we can see severe and or disseminated adenoviral infections in adult allo stem cell transplant patients. This is rare, much more common in the kids, but it can be life-threatening. We treat this with cidofovir, and we, in combination with pre- and post-hydration and probenecid to reduce the nephrotoxicity. We may be able to use, yes. We have to monitor these patients for myelosuppression as well as nephrotoxicity, and there are investigational lipid formulations of cidofovir that look very promising. Okay, the polyomaviruses. So we have this class. We have JC, which can produce PML or progressive multifocal leukoencephalopathy, which is a usually fatal CNS viral infection in these patients when it occurs. Or BK virus, which is more likely to cause nephropathy, especially in kidney transplant patients, or hemorrhagic cystitis is more common in the allogeneic stem cell transplant patients. And for solid organ transplant patients with BK nephropathy, without rejection, where the number one treatment is to reduce immunosuppression. As far as pharmacological therapies, we have low-dose cidofovir without probenecid. We have a low risk of nephrotoxicity at these doses, but anterior uveitis has been reported in these patients. Or alternatively, we can use leflunomide, ARVA, which is immunosuppressive for rheumatoid arthritis, but has antiviral activity. We have to monitor these patients for myelosuppression, hepatitis, or hemolysis. And ciprofloxacin actually has been shown to inhibit BK DNA gyrase, and we have one trial that showed a 90% reduction in the incidence of severe BK viral infections with prolonged ciprofloxacin prophylaxis. So we're actually doing that in our patients who receive antithrombocyte globulin or our cord transplant patients. So in conclusion, oncology and solid organ transplant recipients are susceptible to a wide variety of infections, bacterial, fungal, viral, and parasitic, which I didn't get a chance to touch on, some of which we briefly reviewed today. And given the complexity of these patients' immunosuppressive therapies in combination with prophylactic and therapeutic antimicrobial therapies, the infectious disease team, as well as the clinical pharmacists, have a vital role in the care of these patients. Okay, thank you guys, and I'd be happy to take any questions at this time.